Now we begin this scientific session with Dr. Ashok Rege, PG award papers. So the papers will be presented by these residents, PGs, and the time slot is 8 minutes presentation and 2 minutes discussion. So first I request chairpersons Dr. Bhole sir to chair the session. Welcome sir. Dr. Manoj Belsare sir to please chair the session. And I request our judges for this session, Dr. Sarang Jinturkar, please occupy your chair of judge. And Dr. Praveen Sonovatikar, yes, please. So I hope we can start the session now. So the first presenter, sorry, before that there are, it's a total 8 minutes. So 7 minutes for residents, at 7 minutes one bell will ring, and then at the end 8 minutes. So total 8 minutes are there, and for 2 minutes it is for discussion. Okay, so you should try to finish within your time, because that will also calculate for your markings. Okay, so that will be counted, and the files here again. So I think we can start the session now. So the first presentation is now. Rahul, Dr. Saloni Chaudhary. Saloni, Dr. Saloni is there? Saloni, you are going to present the paper. Please proceed. So Dr. Saloni, it's 7 minutes, one bell will hang, and then at 8, so 2 minute discussion. Okay. So timer, sir. Okay. Sure. All the best to all.
Very good morning to all the dignitaries and my fellow colleagues present here. Today I, Saloni Chaudhary, junior resident, would be presenting a paper on clinical and radiological correlation of involvement of the various paranasal sinuses in post-COVID-19 mucormycosis cases in our tertiary care institute. We all know COVID-19 was caused by SARS virus, and the initial picture of the disease consists of cough, high-grade fever, generalized malaise, shortness of breath, anosmia, agizia, diarrhea, and malaise. ENT has been extremely relevant in the management of the coronavirus pandemic from the very beginning, initiating from the nasopharyngeal swab sampling to declaring anosmia as a symptom marker. Recently, we came across the most dangerous and the worrisome outcome of the disease, which is mucormycosis. Mucormycosis was previously called zygomycosis. It's an invasive fungal infection, which is a saprophytic fungal infection, mostly from the class of Rhizopus, mucor, rhizomucor, Cunninghamella, Apophysomyces, and Lichthemia. R or Rhizae being the most common organism isolated from patients, approximately 70% of them. The disease clinically presents as the Rhino orbitocerebral mucormycosis. Is going to present in the nasal sector as nasal blockage or crusting, nasal discharge and occasional episodes of epistaxis, facial pain and facial swelling, in the ophthalmic region proptosis, ptosis, chemosis and ophthalmoplegia, and various neurological signs and symptoms which could indicate intracranial extension of the disease. The risk factors include indiscriminate use of steroids that has happened rampantly during the COVID pandemic, patients who have received organ transplantation, the use of industrial oxygen and unclean water in the humidifiers, and uncontrolled diabetes mellitus. The different clinical presentation of the disease include Rhino orbitocerebral mucormycosis, the most common one that we would be discussing further, pulmonary, cutaneous, gastrointestinal, disseminated, and a combination of these variants. The complications include cavernous sinus thrombosis, multiple cranial nerve palsies, visual disturbances that could potentially lead to a visual loss, intracranial extension, carotid artery or jugular vein thrombosis causing paresis. 50 to 80% rate has been the disease mortality if not detected early and not intervened in time. That could lead to early complications as well. There was a sudden outbreak of these multiple paper articles, and that's when we realized that a new surgical pandemic had begun, and this is when we decided to step in. We decided to conduct a study, and the aim of the study being to correlate the clinical and radiological findings, thereby assessing the involvement of the various paranasal sinuses in post-COVID-19 mucormycosis patients. The type was a descriptive retrospective study with a sample size of 198 patients. The inclusion and the exclusion criteria are as follows. The management that we had followed in our institute at that time was patient was encountered at the OPD or casualty, after which a detailed history taking with clinical examination was done. History primarily focused on the associated comorbidities. Radiological investigations, a CT scan or an MRI. Medical management, injection amphotericin was started. We had liposomal or the lipid complex or the conventional ones present in our institute. Pre-anesthetic evaluation was done with routine blood work, ECG, chest X-ray. Then patient was planned for surgical management and eventually the post-operative management that include prosthesis and further medical management. What we realized in this pandemic that it is basically a multidisciplinary approach that is the only way forward. We had pathologists, microbiologists, radiologists, everybody coming in together to manage every single patient. These are a few photos from the microbiology department of our institute. The fungus has been grown on lactophenol cotton blue, and it shows aseptate or pauciseptate hyphae, which usually branch at around 90 degrees and the thickness being around 10 to 20 micrometers. Now the radiological procedure features. The institute protocol was for CT scan 0.6 mm cuts were used, the area covered being infratentorial to palate, and for MRI, PNS, brain and orbit. Without contrast, 3 mm cuts for patients who had renal failure and there was high creatinine, so the gadolinium contrast could not be used. And for with contrast, it was a 1 mm cut, area involved infratentorial to palate. The most famous and the classical black turbinate sign, which is basically because of the angioinvasive nature of the fungus that leads to necrosis of the tissue. The MRI here shows destructed inferior and middle turbinate along with mucosal thickening in the right maxillary sinus. This is a T2 weighted MRI, a coronal section showing mucosal thickening in the left maxillary sinus. The MRI here, axial section, shows the destruction of retroventral fat pad, which could indicate the disease extending to the infratemporal fossa and the pterygopalatine fossa. This MRI shows a hypointense lesion with a rim enhancement suggestive of cerebral abscess. The same has been shown in sagittal section to indicate the importance of the various sections. Axial, coronal and sagittal together will give us an impression and a proper picture of the disease. The MRI here shows cavernous sinus thrombosis of the right side. There is obliteration of the lumen of the vessels indicating thrombosis. The observation of our study has been presented in numbers and percentages. To start with the demographic data, we encountered more male patients, around 66%. The age-wise distribution, we encountered more patients in the age group of 54 to 72 years. In the presenting symptoms, we found most common to be facial pain. This is a small video of a DNA that shows extensive nasal crusting and discharge in one of our patients. The comorbidities most common has been diabetes mellitus with 59.09%. In radiological features, the most common finding was pansinusitis of 84.4%. In 93 and 52% males have recovered, while 26.26% of females have recovered. So results in 14.64 patients were either clinically negative but radiologically positive, and if they were clinically positive, by the time they presented to us, the disease had extended a lot. So radiologically, we got more signs and symptoms. 84% patients of pansinusitis had orbital
Hello, I think she needs to stop. Yeah.
Yes. This is the conclusion for the study, that radiology is very integral for the management of the disease, and multidisciplinary approach is the only way forward to tackle the surgical pandemic. Thank you.
Okay, thank you very much. Questions? Question answer.
Saloni, what was the age group?
So 54 to 72 years was the most common age group.
Have you performed HIV in all these patients?
Yes, sir.
You are not mentioning, if I missed it.
No, sir. In the pre-anesthetic evaluation, we do an HIV workup of all our patients.
HIV and HBsAg.
Yes, sir.
Hello.
Good morning, sir.
Good morning. What was the main factor that was responsible for the sudden or acute surge of mucor?
So, industrial oxygen and use of unclean water in the humidifiers and uncontrolled diabetes mellitus because of the excessive use of steroids has led to this pandemic.
Pollution due to factories may or may not be there at all places.
So that could be possible, but we did not have an occupational data of the patients. So I would not be able to comment on that.
Okay.
How many of your patients, hello?
Yes.
How many of your patients had exposure to industrial oxygen?
So around 80%, and 60% of them were referred to us from the medicine wards and the ICUs.
So 80% on industrial oxygen?
Yes.
And how were like home patients? They never visited hospital or never visited any medical facility?
So in 6.56%, it was an incidental finding, just because they had the respective comorbidities, and because of the surge and the awareness that was created, they had come to the setup and they were eventually diagnosed on radiology.
Hello, what is the difference between the industrial, I am Rege is speaking.
So, yes.
What is the difference between the industrial oxygen and the medicinal oxygen? Do you know? Because you said 80% of the, we are given the industrial oxygen, but do you know the difference between medicine? Because whatever we are getting is all industrial oxygen actually.
Yes, sir.
So you cannot say 80%, it's at 100% then.
Okay.
Yeah, I think that is over. We can move on to next.
Thank you,
presentation.
Namaste. Thank you, sir.
Thank you.
Please collect your certificate from chairperson. Dr. Bhole, sir, please hand over the certificate. Saloni, you collect the certificate. The participant. So may I call the next speaker, Dr. Shilpa, for a presentation.
श्रुती खंडागळे ना
शिल्पा गर्जे, sir.
एक नंबर अच्छा शिल्पा गर्जे एक नंबर
Shilpa Garje. Yes. You can start.
Good morning to all. This is Dr. Shilpa Garje, junior resident. Today I am going to present a paper on the topic significance of the nasal septum angulation and its association with the rhinosinusitis with the symptom score and the visual analog scale. Introduction. Rhinosinusitis is a group of disorders characterized by inflammation of the mucosa of the nose and paranasal sinuses. Diagnosis of the acute rhinosinusitis is based on the clinical grounds with a little role of imaging. Acute rhinosinusitis is mainly viral in origin and tends to be self-limiting. Antibiotic therapy is usually not needed until 7 to 10 days after the onset of symptoms in an upper respiratory tract infection. Resistance is developing amongst pathogenic bacteria in part due to overprescription of the antibiotics. It is now clear that chronic rhinosinusitis is a heterogeneous group of disorders characterized by inflammation rather than infection. Anatomic abnormalities were well recognized as a significant factors involving in pathogenesis of rhinosinusitis include a deviated nasal septum and the paraseptal structural abnormalities. These abnormalities have led to obstruction of the osteometal unit and subsequently causing the development of the rhinosinusitis. This is pivotal as the nasal septal angulation would influence the management of the rhinosinusitis patients. In addition, it is also very prudent to determine the severity of the nasal septal angulation before performing the very first surgical intervention such as septoplasty and the functional endoscopic sinus surgery. A very comprehensive evaluation of the nasal septal angulation is crucial in order to achieve the best surgical outcomes without requiring the reoperation. Aims and objectives of the study were: the aim of the study was to determine the association of the angulation of the nasal septum with the severity of the rhinosinusitis as measured by the symptom score and the visual analog scale. The methodology includes 50 patients who were diagnosed with the rhinosinusitis and fulfilled the selection criteria were assessed for the symptom score and the visual analog scale, and the measurement of the angulation of the nasal septum was performed through a coronal view of CT paranasal sinuses in a bone window setting. The inclusion criteria was: the patient older than 18 years diagnosed with the rhinosinusitis and carrying indication for a CT scan of paranasal sinuses were included in the study. The exclusion criteria was: the patient with the history of the nasal trauma, septal surgery, septal hematoma, septal perforation, concabulosa, sinonasal tumors were excluded from the study. Symptom score were comprised of rhinosinusitis symptoms, namely postnasal drip, hyposmia, headache, fever, halitosis, ear pain or fullness. Each of the symptoms were scored by patients between 0 to 10. A score of 0 means no symptom at all, and a score of 0 represents the worst symptoms experienced. Then the total score from each symptom was categorized into either mild, that is 0 to 30, moderate 31 to 60, or a severe 61 to 90. Patients recorded their symptom score based on the symptoms that were experienced during their first presentation at the clinic. Subsequently, the patients were assessed for the overall disease severity by visual analog scale scores. The severity of the disease was categorized as either mild, moderate or severe. The scale was 10 cm long line where the 0 represents not troublesome and the 10 represents the worst thinkable troublesome. The interpretation of the visual analog scale scores is as follows: the mild is up to 3, moderate is more than 3 to 7, and the severe is more than 7 to 10 points. In evaluating the severity, patients were asked to mark on the visual analog scale. Then the measurement of the angulation of the nasal septum was performed through a coronal view of CT paranasal sinuses in bone window setting at the osteometal complex cutting. The landmark used was the maxillary ostium and the lateral to anterior 2/3 of the middle turbinate. The angulation was determined by the angle, the line drawn from the superior insertion of the nasal septum at the crista galli to the inferior insertion of the septum at the maxillary crest level, and the line drawn from the superior insertion of the nasal septum at the crista galli to the apex of the septal deviation. And the classification was: normal includes 0 to septal angulation less than 5 degree, mild includes 5 to septal angulation less than 10 degrees, moderate is 10 to less than 20 degrees, and severe is septal angulation more than 20 degree. Here is a CT scan of one of my patients from the data. Showing the angle of 6.7 degree, which is under mild, and the another video showing angle 11.7, which is under moderate category. Now let's come to results. 50 patients were diagnosed with the rhinosinusitis and fulfilled the selection criteria, were assessed for the symptom score. In this study, the median age is 33.5, where 68% of the male and the 32% of the female patients were included in the study. The symptom score of the patient in this study is 32.5, where the minimum score was 15 and the maximum score was 70 from this histogram. And the mean visual analog score of the study from the this histogram is 5.12, where the minimum score was 2 and the maximum score was 10. This study has revealed the 3 patients have normal category of the nasal septal angulation, that is less than 5 degree, 29 patients have mild angulation, that is 5 to 10 degree, and the 18 patients with the moderate angulation, that is 11 to 20 degree of the nasal septum. However, none of the patients have severe type of nasal septum. Discussion. The study was conducted on the 50 patients of both the sexes above the 18 years who presented to the ear, nose and the throat outpatient department with the nasal complaints and the deviated nasal septum. The study population had majority of the age group 21 to 30 years with the maximum age of 48 years with a male to female ratio of 1.5:1. The probable explanation to the disease being the most common in the middle age is that the people in this age group are more exposed to the environmental pollution and are more aware and conscious of their health and can access the medical facilities at the earliest. In our study, we reviewed the CT images of the 50 patients with rhinosinusitis. Study compromises of the 34 males and the 16 female patients if we combine the parameters of the symptom and the visual analog scores. Most of our patients fell under the moderate category in terms of the symptom severity and the quality of life. It means that our patient recruited in this study actually had a significant symptom of rhinosinusitis with the impaired quality of life. These are few studies included in my study. Conclusion, this study has showed that the severity of the deviated nasal septum angulation was significantly associated with the severity of the rhinosinusitis based on the symptom and the visual analog scores. Thus, the angulation of the nasal septum is needed to be examined meticulously during the first presentation at the oral clinic with the CT scan in a clinically indicated cases. Consequently, the angulation of the deviated nasal septum is imperative to be addressed during the very first endoscopic nasal and the septal surgery in order to ensure the optimum of post-operative outcomes and prevent the ORI operation and its unwanted complications.
Your time is over, Shilpa. Thank you so much. Topic is open for discussion. Please.
Yeah. Do you operate all the septums?
No, sir.
Okay. Are you doing face surgeries individually?
No, sir.
No. Do you know about high DNS?
Yes, sir. It will be posterior above the level of middle turbinate.
Okay. Now, my suggestion to you would be, whenever you do presentations, don't put so much of lines. Just mention the points and you explain on your own.
Yes.
If you need to read slides, we could have read it as well. Please make sure next time.
Yes.
Have you taken history of asthma in these patients?
No, sir.
You are not mentioned, it appears, that's the reason I asked.
Yes,
Secondly, you said that angulations, basically you are taken. Now there are coronal sections various and they go in different way, So
Yes,
which
sir.
you select? Because it should be constant. No, for every patient it should be, then only you can present this. So which section you select?
Sir, actually that is not the common for every patient, where the most septal spur is visible.
But spur may not be with every patient.
Yes,
Patient
sir.
may be having with spur, without spur also patient may have the deviation.
Yes, sir.
Then? Thank you.
In OPD patients, many of the patients are having actually bogey terminates, as well as in case of chronic nasal obstruction, you can't see the properly posterior part of the septum also. You
Yes,
can
sir.
mention.
Sir, in that patient, we used to do endoscopic examinations.
But you can't see no. This obstruction is there, no.
Yes, sir.
Then
Mm,
how you are studied in these cases? Okay, no issue.
Thank you, Shilpa. Please collect your certificate. I request Manoj sir to hand over the certificate. Next is Shruti Khandagre. She will be presenting her award paper.
Good morning, everyone. I am Dr. Shruti Khandagre, and my topic for today is evaluation of myiasis in a tertiary care center of 200 cases. So the introduction is myiasis is in otorhinolaryngology can be traced back to the ancient Hindu mythology, and previously it was called as scolchiasis, and the term myiasis was first coined by W.F. Hope in 1840. So infestation of the live human or other vertebrate host with fly larvae belonging to the insects of order Diptera is called as myiasis, and human myiasis can present as oral myiasis, nasal masses, ocular masses, or other types like genitourinary masses, anal masses, cutaneous masses, and depending on this, it is classified. So masses can be classified according to the presentation and according to how they are like obligatory masses and then facultative, or how the spread occurs, or accidental. So oral masses can lead to perforation of the tympanic membrane, hearing loss, hemorrhage, and rarely the larva can migrate transcanal into the brain and into the meninges. So obligate masses, that is the one that feeds on the human flesh, create nasopharyngeal cavities, digestive tract boards, and even involve any internal organs of animals and humans. So larvae can be deposited into the eye also, causing painful ophthalmomyces resembling a foreign body in the eye sensation. Then inflammatory reaction at the site of larvae position is due to mast cell activation and IgE production, which may also limit the larval development. Then flies are generally attractive to odor of decaying necrotic tissue, and which can rise from chronic otorrhea or sinusitis. Certain populations are particularly susceptible to infestations, which include children younger than 10 years of age and adults with mental or physical disabilities. So the methods that we had carried on, the study was conducted at our institute from Jan 2017 to 2019. And on complete ENT examination, irritable and blood stain discharge was seen in oral cases, and discharge from nose and nasal cases, and whitish maggots were seen. After installation of turpentine oil, maggots were removed, and after removal, otoscopy and nasal endoscopy was done, and all patients underwent routine blood investigations, and patients were discharged from the hospital, and antibiotics oral drop were advised. And they were followed up for 6 months. Over the 2 years period, total 200 cases of masses were seen, and the youngest that was seen was in a 11-month-old child, and the oldest was seen in 70 years of age. The female preponderance was basically seen, and most cases were from the rural background. So oral masses occurred from May to December, and the peak incidence for both was seen in September to October, and 176 cases were of nasal masses, while 22 cases were of oral, and 2 cases were of ocular cases. And in oral masses, passage of worms was seen, ear discharge was seen, and painful ear was seen, otalgia. So these were the most common presenting symptoms, and examination revealed maggots in all cases, and perforation of the tympanic membrane, blood stain discharge, otitis externa, and ulcer over the pinna was also seen. In nasal masses, epistaxis was seen, a foul smell was seen in most of the cases, and passage of worms were seen, and pain in the nose. So examination revealed maggots in nose with necrotic tissue, foul smell in 100% of the cases, and all cases were suffering from primary atrophic rhinitis. So swelling of the nose was also seen in about 77% of the cases, and 2 cases were of ocular masses. So all patients were treated with turpentine oil, which was followed by manual removal of the maggots, and later nasal douching was also done, and oral and maggots were also removed by Tilly's forceps, and all patients could thus be maggot free in 2 to 3 days, and broad spectrum antibiotics were given in all cases, and all patients could be discharged from the hospital from 5 to 7 days, and no complications were encountered. This is the data of the presenting features and signs and symptoms of oral masses and nasal masses respectively. As you can see, in the ear, passage of worms, perforation, and CSOM, history of CSOM is most commonly presenting features, and in nose, passage of worm, necrotic tissue, and foul spelling, and atrophic rhinitis, epistaxis is usually seen. So discussion, masses is a problem in tropic. occurs rarely in the temperate zone. Most commonly, the families are Muscidae and Saccharophagidae. Of the order Diptera are responsible. In Muscidae, you can see Musca domestica, that is a house fly. The important genre of the families are Luciella and Chrysomia are the most common causative flies. Chrysomia, oral myiasis has been reported to occur more frequently in children. And in our studies, females outnumbered the male, and the reason for this mostly being as it was from the rural origin, male is better cared for and looked after. Then myiasis has been reported to have a seasonal variation, and like in our present study, myiasis was seen from May to December with peak of September to October, and pain and discharge has been reported as the presenting symptoms in most of the cases. And in the present study, it was observed in 41.97 cases, and the incidence of blood-stained discharge was reported by others too. We had compared it with other studies, and in similar cases, acute suppurative otitis media was associated with myiasis. And so these are the pictures that we had seen. And one is of the nasal myiasis and the other is of oral myiasis. And in conclusion, we see that in otorhinolaryngology, myiasis is a rare complication and is the rare manifestation, and meanwhile, the overwhelming majority of the cases has been successfully treated, and good hygiene and early detection of myiasis is advocated to be followed to prevent complications.
Over. Thank you, Shruti. Topic is open for discussion.
In your study, you have mentioned here. This side.
Yes, sir.
You have mentioned the seasonal variation.
Yes, sir.
Why it is more in September and October?
So because in September and October it is more like a tropic area, like because of the humidity.
What else?
Breeding season, sir, of the flies.
Whose breeding season?
Flies.
Flies.
Yeah.
That you should mention.
Yes.
Okay. And secondly, you have mentioned that male are well protected and the females are that the preponderance is more.
Yeah.
That is totally wrong.
So because in atrophic rhinitis it is female
atrophic rhinitis, it is because of the hormonal changes they land into atrophic rhinitis.
Yeah,
That
we
you
also
should
give
mention.
estradiol
This is a long
also.
statement. Okay, you change the statement.
Yes, sir. Yes, sir. So that is what we had seen in our cases.
Seen that because of the hormonal changes.
Yeah.
Okay.
You said something about the turpentine oil, you know.
Yes, sir.
You said that patient has got the oral also maggots. Now, have you ever used turpentine yourself?
Yes, sir. In nasal myiasis, we
Does
have
it give
done.
irritation to the skin?
Yes, sir. Irritation, sir.
Because
Basically,
whatever turpentine is only used for the external use.
Okay, sir. It is for nasal. We have used turpentine.
But that is something wrong. It's totally wrong because when you irritate the maggots, they will go deep inside.
Okay.
So the maggots, they should come out.
Yeah.
You want that the maggots should be come out. So they should be partially anesthetized. So you put the 4% xylocaine, that will be better.
Yeah. So we put xylocaine
No,
also.
but you
I've
never
written-
mentioned then, madam.
Yeah. We've put xylocaine also and turpentine. We anesthetize and then so that the patient doesn't have irritant over there.
You have to literally pick up and then what to do? You just throw it? No, you
you
have to put it in the water.
yeah.
You have to put
Hot
it in the
water.
water,
Yeah.
Then only they will be die. Otherwise, again the problem will occur, the patient. Secondly, what about the diabetics? You never mention about the, because that's also equally important.
Comorbid condition.
Because
Yeah.
in the conditions where the sensations is less,
Yes, sir.
in those patients they
comorbid,
do get this.
Yes, sir. So there were cases of diabetes also, immunocompromised people.
You never mentioned.
Sir, it was only the presenting symptoms that were
No, but
mentioned over there.
diabetes is equally important for us, basically. Because
Yeah.
then you said something about the pena, in one patient, there were 9%, you said that pena is ulcerations of pena. You mean that patient had a perichondritis?
Yes, sir. One of the patient had ulcer over the pinna and maggots were seen over there. Over the
No, but-
ulcer of the...
But was the patient had a perichondritis?
Yes, sir. Perichondritis he did. And he was diabetic also, sir. So,
Thank you.
thank you, sir.
Just a minute. I would like to just suggest you, your presentation is in award category, so you should not mention your PG teacher's name and institute's name.
Thank you, Dr. Jitendra. Shruti, please collect your certificate. Dr. Bhole, sir, please hand over the certificate. May I call the next speaker, Dr. Harshaya Gowde?
Hello. Good morning, all respected dignitaries. My topic is the upsurge of head and neck space infections in our institute after COVID-19 infection pandemic. As we all know that many infective and inflammatory disease has increased manifold after COVID-19 infection. One of them was a dreadful disease, mucormycosis, which was tackled in a very excellent way by our ENT fraternity. Another one of them was infective ailment, which we found was which took a upsurge in after COVID infection was head and neck space infection. So we have taken data from our institute for the last 6 months to show the same. Spaces of head and infection. We have enumerated some spaces of the head and neck space infection. Basically, the superficial and the deep fascia of the cervical fascia in the neck will, in relation to them, we have the spaces of the neck. The most common space, important space of the neck and head and neck are retropharyngeal space, prevertebral space, submandibular space, parapharyngeal space, and parotid space. This is just a diagram showing all the spaces. The etiology, in most of the cases, the cause of the infection is unknown, so idiopathic. Then we have dental caries, and the third is lymphadenopathy. Risk factors, the most common risk factor which we found in our institute was poor oral hygiene, followed by diabetes mellitus, trauma, and chronic renal disease. Common organisms involved were Staphylococcus aureus, Streptococcus, H. influenza, Pneumococcus. In our institute, what we found was Staphylococcus aureus, mostly MRSA, was the most common agent. Symptoms. The most common symptom with which patients came to us was swelling over the cheek or the neck region, followed by pain, fever, reduced mouth opening, difficulty in swallowing, toothache, and change in voice. Signs, the most common sign which we found in the patients was swelling, then tenderness, dental caries, erythema, and those patients who came with Ludwig's angina had bulge over the floor of the mouth. These are the photos of our patients who came with the symptoms. The most common symptom was, sign was swelling and dental caries, along with the reduced mouth opening. What we observed in our institute was, this is the demographic data shown. First is age distribution. The most common age which was affected was from 0 to 10 years of the age, followed by 21 to 30 years of age group. The total number of patients which we found during the last 6 months were 43 patients. This is just a bar graph showing the distribution. The data which we collected was from April 2022 to September 2022. This is the demographic pie chart of sex ratio. Males were 22 and females were 21, which was the almost equal preponderance. Site of infection, the most common site which was involved was submandibular abscess space, followed by parotid, then submantle and parapharyngeal. Etiological factors, the most common the cause of the infection was unknown, followed by dental caries and lymphadenopathy. Associated comorbidities, again poor oral hygiene was the common associated comorbidities. The total number of patients were 21, followed by diabetes, which was 13. When we asked the patients about the COVID history, 25 patients of ours gave us COVID positive history, or they had a contact with the COVID positive patients. And 18, they didn't give any history of COVID positive. Complications, out of 43 patients which we had, 4 patients developed severe complication. One of the patients developed necrotizing fasciitis. The second and third patient developed, 2 of the patients developed AV obstruction along with mediastinitis and septicemia, and only 1 patient developed septicemia. The definitive treatment of abscess is incision and drainage. Prognosis, in our institute, we had complete recovery in 41 patients and only 2 unfortunate deaths. This is the data taken from the October 2021 to March 2022 of head and neck space infection. So in this period, we found only 9 patients, out of which 4 were males and 5 were females, with 4 submandibular, 2 parotid, 2 parapharyngeal, and only 1 Ludwig's angina. Comparing the data of October 2021 to March 2022 and April 2022, September 2022. In April till September 2022, we had 43 patients, out of which 22 were males and 21 were females. The most common age group which was involved was 0 to 10 years of the age group. And the data collected from October 2021 to March 2022, we had 9 patients, out of which 4 were males and 5 were females. Thus, we can see that there was a 5-fold increase in the cases of head and neck space infection, which was observed by us. So what we noticed was that there was an upsurge of head and neck space infection in post-COVID period. And on detailed history of coronavirus infection, most of the patients, at least 25 patients of ours, had COVID-19 positive history. So therefore, we can hypothesize that coronavirus 19 had similar contribution in the rise of the head and neck space infection, similar to its effect in mucormycosis. It could be because of immunocompromised state, injudicious use of steroids, diabetes mellitus. However, dental caries and poor oral hygiene remains the topmost cause of source of infection in these patients. Further long-term study and correlation is required to establish the relationship between the COVID-19 and head and neck space infection. This was just an observational study.
Thank you, Harshya. Topic is open for discussion.
We have a mixed population here, private practitioners, government hospital, medical colleges. Is the age group 0 to 10 that common with the neck infections? I really doubt. Most of them we would get in diabetes, elder population. So
Yeah.
I'm little surprised that your highest number come from 0 to 10, right?
Yes.
And you yourself said that the dental caries is the biggest contributor along with diabetes and immunocompromised states, right?
Yes, sir.
So we are really surprised to see 0 to 10 age group coming with big numbers.
See, first and foremost, there cannot be 0 age. It starts from 1 day. So you cannot mention that 0 age,
Yes, sir.
I don't agree with that. That is one. Your topic was the head and neck space infections.
Yes, sir.
I don't know whether you should talk on the preauricular sinus and other sinuses, but you must talk on the arches related infections, what I feel personally, because they are also equally and more common. If we get the patients of bronchial fistulas and all that, and we have got a lot of patients coming to there. So I think you are not considered. You are not mentioned about the pre-masseteric space. There is a known as pre-masseteric space which get affected and then patient develops what is known as the Ludwig's angina. No, I want to ask you one question.
Yes.
You said that you operated under which anesthesia?
So in children, we have taken them under general anesthesia.
Even if the patient has got Ludwig's, you have done the general anesthesia. Patient has got a trismus. How can you give the Ludwig's? How can you give the general anesthesia?
So no, I said for only for smaller age groups who are not cooperative, we have given them general anesthesia. And the patients with Ludwig's angina which we had were all adults.
For general anesthesia, which drug was induced?
Sorry, sir?
Which drug was induced for the general anesthesia? See, you are a surgeon, doesn't mean you should not know the names of the drug. Huh? I feel sorry for that. You know, we sit outside and anesthesia. Have you complete? Then I will come. It's not wrong. It's absolutely wrong. You must always be the patient. Then only the patient will get the confidence that my doctor has operated. So which drug we have used? You know?
So propofol.
Propofol. What is the advantage of propofol over the?
Sorry, sir?
What is the advantage of propofol? Giving propofol, you know?
So it is short acting, injectable, and the patient can come out of the anesthesia fast. The recovery is fast.
Any other drugs sometimes they give for the children? You know? Ketamine. But in pediatric age group, they like to use ketamine, you know, than even the propofol, you know. Thank you.
Thank you, sir. Thank you, Harsha. Please collect your survey from Dr. Bole, sir. Before announcing the next participant, I want to announce there is a session of pre-paper in the Pharmac hall. So at 9:30 that session will start. So those residents who are participating in the free paper, and I request chairperson also to be at 9:30 at the hall, so there will be any time. Thank you, sir. So may I request next speaker Sangram Das. Sangram, you should have uploaded it yesterday only. I requested 3 times. Now 11th hour, you are wasting our time actually. So yesterday 3 times I announced. If it's not ready, I can call the next speaker. No, Doctor. Okay, proceed. Timer.
A very good morning to one and all present in this auditorium. I am going to present a paper on our experience with recovery from newly onset anosmia and agusia in COVID-19. As we all know, coronavirus or COVID-19 is a highly contagious zoonosis named by World Health Organization February 2020, caused by severe acute respiratory syndrome COVID-19 virus. It is rapidly transmitted from human to human by respiratory secretions, airborne disease, and it gradually evolved into a global pandemic. Coronavirus can produce symptoms ranging from mild common cold-like symptoms to severe acute respiratory syndrome. COVID-19 positive patients are characterized by a variety of clinical manifestations, typically high-grade fever appearing after dry cough. Some clinical pneumonitis develops and progresses, resulting in shortness of breath. According to some epidemiological studies, it could cause olfactory and gustatory dysfunction, especially in mild to moderate forms of COVID-19 infected cases. Anosmia, loss of smell, and ageusia, loss of taste, are newly presenting independent symptoms with common symptoms such as fever, dry cough, shortness of breath in COVID-19 positive cases. They are also associated with muscle ache, which is referred to as myalgia, headache, sore throat, rhinorrhea, chest pain, diarrhea, nausea, vomiting, conjunctival and nasal congestion, sputum production, fatigue, hemoptysis, and chills. Some authors reported that there are 3 mechanisms for anosmia in COVID-19 patient. The first one being the local infection of the support cells and the vascular pericytes in the nose and olfactory bulb that may affect the bipolar neurons or mitral cells. Damage to support in the sensory epithelium that may indirectly influence the signaling pathway from the sensory neurons to the brain, or damage to the sustentacular cells and Bowman gland cells that could lead to diffuse morphological damage to the olfactory sensory epithelium and altering the smell perception. Ageusia may be secondary result of olfactory dysfunction. However, the ACE2 receptors, the angiotensin converting enzyme 2 receptors, are the main host cell receptors in the COVID-19 for binding and penetrating cells widely expressed on the epithelial cells of oral mucosa. So, damage to these mucosal epithelial cells may explain ageusia. Since there have been a rapidly growing report of significant increasing number of patients presenting with these symptoms, they affect the quality of life. So we decided to observe the rate of recovery in these patients after being affected by these symptoms. So our aim is to describe the occurrence of the olfactory and gustatory dysfunction in patients with lab confirmed COVID-19 cases, like they are being RT-PCR positive, estimation of the recovery rates from the above sensory disorders with laboratory confirmed COVID-19 infections. A study was conducted between March 2021 to June 2021. Total 100 patients with age group 15 to 60 years with COVID-19 infection, and they were RT-PCR positive, having mild to moderate symptoms. Mild symptoms ranged from only low-grade fever, mild cough, and slight fatigue, with moderate symptoms being high-grade fever. Patients after being tested RT-PCR positive were assessed for symptoms and signs of olfactory and taste disturbance. A study was conducted for smell and taste sensations clinically along with phone interview to analyze the prevalence and estimate the recovery of a 10-item based Dynacron questionnaire, which is dysfunction with nasal chronic or chronic nasal dysfunction. We included patients that were those who were diagnosed with COVID-19 pneumonia after being tested RT-PCR positive. The age group ranged from 15 to 60, and both sexes were included. And in the exclusion criteria, we excluded patients who had previous history of loss of smell, taste, or both before the study was conducted. Patients with previous history of head trauma, acute or chronic rhinosinusitis, allergic rhinitis, dementia, malignancy, or abnormal nasal anatomy. Patient who had psychological disturbances, patient who lost follow-up, we just excluded those patients from the study. This is the Dynacron questionnaire. There are 10 questions. We range each question score from 0 to 10, and there are 10 questions and the total score being 100. So the recovery rate we decided to calculate at the days 7, 14 and 21. At the end of those days, a score between 0 to 5 out of 100 would estimate a complete recovery. A score between 5 and previous score obtained at day 7 would give a partial recovery, or score equal or superior to the previous score, that is on day 0 when we gave the questionnaire, would be no recovery. In our study, there were more of a female dominance, like 64% were female and 36% were male. And gender-wise distribution of symptoms are also similar. The females had more symptoms than males. And when we calculated the recovery rate at the end of 7th day, 14th day and 21st day, according to the study conducted in Harvard Medical School for COVID-19, viral load is a key factor to determine susceptibility for long-term anosmia, as the severe acute respiratory syndrome COVID-19 invades the cell, leading to inflammation which knocks out the smell. For early recovery, stimulation of smell and taste bud with rose water and lemon, as these neurons have capability to regenerate with daily twice sniffing of rose water and lemon test. The behavior of COVID-19 is different in different patients, preventing disease suspicion leading to delayed diagnosis. Though the mechanism of smell and taste loss is unclear, the condition may gradually improve on its own with majority recovering spontaneously. Like, we did not give any sort of higher medications in the patient. We just observed. On day 0, they were having a score of like more than 10, and the end of day 21, the score gradually decreased. So the disease tend to decrease spontaneously on its own. So consideration of loss of smell and taste as part of screening and diagnostic approaches for COVID-19 prevent spread and aids in detection. Newly onset anosmia and agusia are common in early stages of COVID-19 disease, affecting more commonly in younger population. Anosmia and agusia prevalent in mild to moderate symptoms of the disease. Recovery in most cases were rapid and complete. First, recovery of smell and taste sensation is improved in patients with regular rose water inhalation and use of lemon. So early screening test performed in suspected COVID patients allows early diagnosis and treatment. So these are my references, sir. Thank you.
Thank you. Thank you, Sangram.
Yes,
Topic is open for discussion, please.
Okay, Sangram. So this was all responses were subjective, right?
Subjective.
You gave questionnaire
Yes,
and
sir.
patients
Yes, sir.
answered. Is there a objective testing, especially for the gustatory ones?
Sir, we did not perform any objective testing, but we can do some tests like if we tell the patient to inhale some substances. Basically, we did not do any.
No, that is for, I'm asking gustatory. It's for the tongue, not for the smell.
Sir, we can give patients different tastes based on different locations of the tongue, and we can observe the results.
In fact, there is electrical gustatory
Yes,
testing
sir.
material that is also available. If
Yes.
one wants to, you can do that. You said you refer 7 patients who did not improve to the
Yes,
higher centers.
So higher centers means we just refer them to a clinical psychologist, because and if they further they tell that they should go to higher centers. First, before going to higher centers, we refer them to clinical psychologists. If they did not get any results from their counseling, then we should send them to higher centers.
Okay. Did you prescribe steroids to any of these patients?
No, sir, we did not prescribe steroids, sir. We just prescribed some multivitamins. We prescribed, sir, regular exercise. We prescribed meditation after consulting psychologist, but we did not prescribe steroids, sir.
See, you are suspecting a viral infection, right?
Yes, sir.
And
Yes.
this is the commonest cause, viral infection causing these 2 symptoms. So steroids should be the mainstay.
Okay, sir. Thank you, sir.
I want to ask you, first and foremost, what about the malingerers? There are many malingerers. They say that they don't smell, they don't taste. How can you rule out?
Sir, that is why we did not give them any medications. We just waited for the spontaneous regressal of the symptoms after 21st day.
I don't say psychological, I say malingerer, Basically,
might
malingering is
be
something
faking it,
different.
yes, sir.
He knows, but he doesn't want to cooperate with you. That's the malingering,
Sir, yes, sir. Sir, our study was basically subjective, so after taking proper consent and all, we included them in our study.
What about their habits like tobacco chewing or say snuff and all that?
There were patients who had tobacco addiction, sir.
You never mentioned? You are not mentioned in the... Because that is important, no? Because they should be excluded otherwise from your studies.
Yes.
Because you never mentioned. So I thought that you are not done this, basically. Thank you.
Thank you, sir. Thank you, Sangram. Please collect your certificate from Manoj, sir.
Hello, excuse me. Hello. Das.
Just,
Das,
Sangram, just
one.
be on the stage.
In your study, you have mentioned that most of the patients recovered spontaneously.
Yes, sir.
So it was the viral load that was responsible for developing
Yes,
these
sir,
2
I mentioned
symptoms.
about it.
Yes,
Yes,
yes.
sir.
So what do you think? What are those factors for those patients who have developed permanent agusia and permanent anosmia?
Sir, it can be a permanent damage to the olfactory epithelial cells that might have caused this permanent damage to the smell and taste sensations. Sir, in those patients, first we'll try to counsel the patients that it will recover, and if it doesn't, as sir said, we should try some steroids or some advanced medications for them.
So what was the treatment protocol for such patients?
So we just gave multivitamins, we gave vitamin C, and we waited for the results. We just counseled them that it will recover on its own, and we waited for spontaneous recovery. That was our main aim.
In such permanent patients, still you are expecting recovery?
It is difficult to recover from those cases, but
I mean to say, at such a tertiary center, what protocol we have decided or you have decided to follow such patients?
sir, we'll ask them for a constant follow-up, and we will administer.
They will come for constant follow-up.
Yes.
You said these patients study belonged to last year. Have you followed up any of the patients?
They do come, sir.
And for
They
how
do
much days you should wait actually for any neurological disease to recover?
Sir, a minimum duration of 6 months, sir.
6 months to 1 year.
Yes.
Thank you.
Thank you all. Thank you, judges. Please collect your certificate. Sir. So I call upon the next speaker, Dr. Rahul.
Good morning to all. Okay. I am going to present a topic on a comparative study between canal wall up versus canal wall down mastectomy in cases of chronic suppurative otitis media. Myself, Dr. Rahul Dubale. I am a third year junior resident. A brief introduction regarding the topic. The chronic discharging ear is still one of the most common problems the otorhinolaryngologist in India and other developing countries encounter. Although thanks to the advent of newer antibiotics, the incidence of acute suppurative otitis media and its complication has reduced. Still, the chronic suppurative otitis media and their complications are still prevalent. The continuation of infection and the bone eroding properties of granulation tissue, cholesteatoma, seen in CSM are known to be the major pathological process causing their complication. As there is no simple means to eradicate this chronic pathology, appropriate timely intervention by the otologist goes a long way in prevention of these human maladies. Though the complications of CSM can be avoided, still they are on the rise due to unhygienic condition, the poverty, the ignorance of the patient and non-availability of the facilities, on-time facilities. Therefore, there is need to make public aware of the serious nature of illness, the importance of early diagnosis and managing so as not only to reduce the morbidity and mortality, but also to give them safe and dry functioning ear. The present study has been carried out to compare the post-operative results of canal wall up versus canal wall down mastectomy with patients with aticoantral posterior superior marginal pathologies of chronic suppurative otitis media. The aim of study is to perform appropriate mastoid surgeries in patients with aticoantral or posterior superior marginal pathology in chronic suppurative otitis media. To follow up the patients post-operatively by clinical examination, otoendoscopy and pure tone audiograms. To study their post-operative results with respect to clearance of disease, improvement in hearing and requirement of post-operative follow-up. I have just shown a diagram showing canal wall down mastectomy and canal wall up mastectomy. I have taken this picture from Shambok. Objectives of my study are gross objective. First and foremost is eradication of disease. Second is prevention of disease recurrence. Third is preservation or restoration of hearing. Material and methodology. Study design is randomized control trial done in tertiary care center. Approximately 60 cases were studied. It was simple random sampling. I would like to go with my results and discussion. As I have already mentioned, I have taken 60 cases with chronic suppurative otitis media with either aticoantral pathology or posterior superior marginal pathology, cholesteatoma or granulation were included in the study. They were randomly segregated into two halves. First half with 30 cases, second half 30 cases. And few of the important outcomes I have compared. The first outcome was disease clearance between canal wall down and canal wall up mastectomy. So the percentage of patient having remnant disease in canal wall down and canal wall up surgery was 6.67% and 13.33% respectively. Percent of patient having complete disease clearance in canal wall up and canal wall down surgery was 93.33% and 86.67%. Second outcome which I have compared was post-op ear discharge between them. Of patient having improved hearing after surgery in canal wall up and canal wall down surgery was 93.33% and 86.67% respectively. So percentage of patient not having hearing improvement in improvement in hearing after surgery in canal wall up and canal wall down surgery was 6.67% and 13.33% respectively. A conclusion, I would like to come to the conclusion of my study. This study consists of detailed history, pre-operative investigation, surgery, post-operative follow-up, evaluation and statistical analysis of data. As I have already mentioned, 60 patients with chronic suppurative otitis media with aticoental pathology were surgically treated and evaluated. Goals of surgical management of CSM are eradication of disease, restoration of hearing, to extent possible maintenance or restoration of normal anatomical configuration. The intact canal wall mastectomy, since the posterior canal wall is maintained, there is significant improvement in hearing. In addition, there are nil cavity problems. Regular follow-up for cavity cleaning is not required. Similarly, in canal wall down mastectomy, a large cavity is created after rendering disease clearance, and post-operative improvement in hearing is less when compared with canal wall up procedures. Also, there is post-operative cavity problem which necessitates long-term follow-up of the patients. The decision to treat chronic suppurative otitis media by surgery, in this case by a canal wall down procedure, is not to be undertaken lightly. Whatever the reason for procedure, patient will become a regular visitor to the outpatient for many years to come and will only be discharged if the cavity is entirely trouble-free and self-cleaning over a number of consecutive visits. So I have completed my presentation, but I would like to specially thank the people who have contributed for the study, as most of them were from tribal and rural areas from where I belong, where I am studying now. Thank you for all the delegates for allowing me to present this presentation, our paper presentation. Yes. Thank you, sir.
Rahul, naam to suna hi tha, but let me ask you a question.
Yes, sir.
You said randomization was done. Yes. So how you decided who did the randomization and how? That which patient will go for canal wall up and which patient will go for canal wall down?
Sir, basically randomization was not on the OPD basis, sir. Total number of mastoid surgeries which were operated, out of which on-table decisions were taken for whether we have to do canal wall down if the disease was in hidden areas, so which was not resectable, and in such patient the canal wall down was done. So such 30 patients, and the patient who underwent only cortical mastectomy, such 30 patients outcome was compared. I would also like to say that there are shortcomings of my study since I have done it only over the duration of 1.5 to 2 years, because long-term follow-up results, I don't have long-term follow-up results with this. Yes.
Rahul, you have mentioned about canal wall up, canal wall down.
Yes.
It reminds me this particular debate is going on since 1981
yes.
when
yes,
I joined ENT. There's something even before that, So, Dege sir is saying even before that. I'll just like to ask you one question.
Yes.
Do you know there is some entity, combined approach tympanoplasty?
Yes, sir. I have
What
heard.
it is?
I have not seen. I have heard virtually and list. See, combined approach is so sometimes if the disease is limited in attic region, okay, in that only the posterior canal wall is maintained. Epitympanic disease, we try to do bondage operation, aticotomy only, limited disease, and sometimes even the tympanoplasty simultaneously we do tympanoplasty.